I got a little talk just a few minutes ago by our next presenter. I got a please don't read all the things I gave you on my transcript when you introduced me.
Read them. Tell it all, brother.
I approached today with a little bit of anxiety. I didn't know what to expect. It's been the dream I told you of this group since we started, that this summit would happen. But I was anxious. But can I tell you my experience so far today? It has been seeing people that I've gotten to know through my 2.5 years in this program share with one another. The number of times I've leaned to my wife and say, you've got to meet her, or you've got to meet him, or this person, they're amazing. And to see you all in one place and to meet more of you has been amazing. I was first introduced to Dr. Carolyn Anglim when the idea for us having students be summer scholars with us, medical students, and we had a theology student who was also a physician, spend 6 weeks studying whatever we decided we wanted to learn and we didn't have time to do, so the students did it for us. And I met Dr. Anglim and was told to call her Carolyn. I still have a problem with that. And was just taken with how kind she was. And how much she clearly loved what she did with students. She loves teaching. She loves hearing from students and nurturing them. It's just obvious. And I did not read her transcript before. So I want you to know Carolyn Anglim, this wonderfully kind and dedicated teacher. And now I'm going to do what you asked me not to. Dr. Carolyn Anglim is an assistant professor in the Department of Bioethics and Medical Humanities at Mercer's School of Medicine here in Macon. Her research focuses on religious pluralism in medicine, and she is published in the American Journal of Bioethics, in the Journal of the Society of Christian Ethics. She has co-edited recent volumes entitled The Religion and Social Criticism, Tradition, Methods, and Values. In addition to teaching integrated bioethics curriculum here, she has mentored medical students and research projects on a range of topics, that's us, including integrations of faith in healthcare, the management of religious conflict, and in medical ethics. Dr. Anglim was recently recognized for her teaching and mentorship with the 2024 Mercer University Early Career Faculty Award. Folks, that's a big deal. And she was recently named the 2024-2025 Sperry Fellow in the Department of Religion at Dartmouth College. Frankly, I was unaware of most of this and am a little more intimidated now, except for her kindness and her inspiration. I proudly give you my friend and the Dr. Carolyn Anglim.
Thanks, Paul. I should have seen that coming. What was I thinking? Let's see. Here we go. It's been so great to work with Paul. You all may not know this, but even just getting a date on the calendar for this event was a feat. Imagine, he's been doing this for 3 years. It's incredible. I apologize. I'm on the right side of a head cold, so I sound like a frog that's been smoking for 30 years. I'm sorry, but we'll do the best I can. If I run out of voice, I'll just hand it over to Hannah to take over. So I'm going to be joined by Hannah and another student who's recorded a bit of her presentation or some of her research. And then we have several students who have posters out in the lobby, and we hope that in the break, following this session. You'll go take a look at those. Some of those students are here in person, and some, their contact information is on there. So if you have a burning question, and I'll say more about them in just a moment. But I heard you, Paul. This is a summit and not a conference. But part of my job here today is to sort of bring in some of the academic literature that's on this topic, religion and health. And for those of you who aren't reading journals all the time, that may seem sort of like a niche topic, but in fact, it's quite rich. There are a lot of methodological approaches that lead to a real diversity of research questions and kinds of areas of interest. So I'm going to try to give you just an overview of what some of that looks like. I certainly can't claim to be comprehensive in any of this. But before I start talking about research questions, I think it's appropriate to name some of the kind of perennial problems that come up when we start talking about religion and health. So one such perennial problem is that we're studying religion and health, but as researchers, we can't quite decide how to define religion or health, for that matter. If you ask a scholar of religion, maybe you corner Dean Deloach at the end of the conference and ask him what religion is, you might be there for an hour talking about how to define that. Same thing if you look up all the public health websites, international health organizations, and you try to figure out what they mean by health, you'll get a pretty wide range of answers. So that creates some, maybe not a fatal flaw, but certainly we have to be cautious, make sure that we're not talking past one another. So core research questions, there are lots of different research questions that come up here. I'm going to name two sort of primary ones, and then I'll point to some other areas of research that I think are interesting. But the first is about whether or not religion and spirituality is good for people. And what they mean by that in the context of health is, does religiosity, however it is we define that, protect or preserve health in some way? Do religious or spiritual behaviors improve people's health? And these, of course, are very interesting questions, but if you go back to my problem that I just pointed to, they're very hard to study. So, for example, if we say, religion is good for people, are we talking about church attendance? Are we talking about prayer or meditation? Are we talking about a certain level of sacramental knowledge, a kind of self-reported connection to the divine? What exactly do we mean when we're talking about religion as a sort of intervention on health? Additionally, it can be very hard to measure religion or spirituality and to isolate the various inputs that might be relevant to the kinds of outputs that we're looking at. So, for example, some studies have said, people who go to church live longer, right? Or people who go to church stay out of the hospital more. But are they staying out of the hospital because they have a great social life? Are they staying out of the hospital because they have access to transportation through a church community, and that's allowing them to see a physician more often? Are they staying out of the hospital because they engage in healthier behaviors as encouraged by their religious doctrine, maybe? Or is it, in the end, because they believe in God? It's hard, sort of from a sort of scientific standpoint to clarify what exactly is it that we're studying here when we are studying the impact of religion on health. So there's kind of a correlation causation problem. And again, I wouldn't say it goes so far as to undermine the research, but it sort of comes up all the time when we're in this area. One area, though, that I think, or sort of one avenue that I think does this pretty well, it's come up a couple of times today, is the research that's on religious coping, specifically religious coping in the face of serious illness or injury. So Dan Flamese is an important voice in this field. Harold Koenig is somebody who publishes a lot on mental health and religion. And a lot of times they're sort of differentiating between positive religious coping and negative religious coping. So there's some good research along those lines where they're sort of isolating a certain sort of habit of mind that's relevant to religious people and evaluating the impact on people's health. And there have been a few attempts to develop like screening tools for religious coping. The R-COPE is one of them. So some good work going on there. I think the second really important question in this area of study has to do with training healthcare providers, which we've talked about several times. How do we prepare healthcare providers to address the spiritual and religious needs of their patients? So what we're looking for in this sort of area of research are really proven pedagogical approaches that are effective in training providers to understand the spiritual needs of their patients. And by understand the spiritual needs of their patients, we're talking about, understand the content of their religious beliefs or commitments, understand the degree of religiosity, right? People are religious at different levels and in different ways. That's why there's sort of diversity within religious communities, maybe even difference in religious level of sort of religious commitment over the course of someone's own life, right? And then third, I think it's about teaching professionals to understand the sort of interpretive processes, these hermeneutical processes through which patients apply their religious beliefs to a new context, a new illness, a new sort of injury, or that they use their illness and injury to start evaluating their religious commitments and revising them maybe in that process. So there's a lot of layers here. And I find this area of research really productive and insightful. There are, of course, some stubborn problems here too. One is that a lot of researchers in this field sort of start with the assumption that there's this persistent resistance to spirituality in medicine. And I want to be clear that I think there's a lot more we could be doing, certainly more training we could be doing, but I don't see that persistent resistance in the field. I think people, healthcare providers maybe aren't asking about religion and spirituality because they don't know how to ask. They're not asking because they hate religion or they think religion is bad for people. It's not this sort of anti-religion bias that's operating in the healthcare space all the time. It's often just a sort of a discomfort and a lack of knowledge and training. So it's something we have to take seriously, I think, in the medical education space. And luckily, there are some good training tools. I'm not sure that these have come up today, but you've probably heard about some of these before. FICA is probably the most well-known by Christine Pilchowski and colleagues. And essentially, these are acronyms or sort of communication tools that we use to teach healthcare providers how to just open a conversation about religion and spirituality. So FICA is an acronym. It starts with trying to understand the patient's faith or belief, the importance of spirituality in the patient's life, the spiritual community that they have to support them, and then how they want those spiritual issues addressed in the medical setting. So FICA sort of helps you run through each of those questions. Spirit and hope are other versions with a similar kind of output. So for the clinicians out there, if acronyms are not your thing, I hear you. I think most researchers in this field would really just accept that some good open-ended questions about spirituality are often just as effective. So something like, what role does spirituality play in your life? Or how does religion and faith impact your medical decision-making? Those are good openers, and prompt some deeper conversation in the medical space. So in terms of training, I think most researchers also would say that the limitations of these training tools are that they're intended to start the conversation, but of course, we also have to train clinicians to respond appropriately to whatever answer they get once they start asking questions. So, that answer could be everything from, yes, I'm very religious, I would like some spiritual support, could you send in a chaplain, to total dismissal and avoidance and a real, sort of discomfort with that conversation and everything in between. So I think that's part of the challenge here is offering both sides of those, and then sort of training clinicians to then keep the conversation open as they go forward. So there are a few other areas of research interest that I won't go into too deeply, but I just want to mention so you're aware. since probably early aughts. Dr. Childs actually mentioned the religious nuns a minute ago, but there's been a real interest in what are called religious nuns, which are people who are claim to be spiritual but are not affiliated in any formal sense with a religious community or sort of traditional faith community, and may not sort of commit to any particular doctrine. And so some of the research has indicated that it's important to, sort of be open-minded about even the way you're phrasing the question, and use the idea of spirituality broadly instead of just assuming that patients operate in this sort of mindset. Well, I'm surprised it lasted as long as it did. There's also been there's a good deal of work on what healthcare professionals believe rather than just what patients believe, right? And some investigations into the viability of like religious concordance between patients and providers. Some of the work on religiously based conscientious refusals sort of goes in this direction. I think there are some real limitations along that front from an educator perspective. I think it's very important to teach our students to be prepared to work with patients of all different backgrounds and sort of walks of life. And while they may end up in a situation where they happen to share some faith commitments with many of their with many of their patients, we're sort of doing them a disservice if we lead them to believe that that's something that they can always, a space they can always work in. So we sort of have to balance that carefully. It's not scalable, maybe, is the way to say it. And then certainly there's been a lot more interest in work in religion and health with a focus on non-Western and non-Christian religious traditions, a lot of work on Islam and healthcare in particular. And then in the last 3 years or so, there's been some concerted effort to bring what is a robust academic literature on chaplaincy into conversation with some of the more traditional journals on religion and health. These two bodies of literature sort of ran parallel to one another for a long time. So some interest in things like how pastoral care affects, patients' emotional well-being or clinicians' emotional well-being, that sort of thing. And then in terms of like suggested reading, if this interests you, these are both older texts, but ones that I think are really wonderful in different ways. The Rebirth of the Clinic is by Dan Solmese, who was a priest for a long time and a physician as well. And he really wrote this book for clinicians, and he argues that providing spiritual care is a sort of moral obligation of healthcare providers, but he's pretty insistent, and I think this is echoing some of the conversation that we just had, that it's the patient who drives the shape of that conversation and sort of sets the terms of that engagement. The Patient's Ordeal is an even older book. Solmese's book is 20 years old. The Patient's Ordeal is over 30 years old, but it's a sort of oldie but a goodie. And he does use some outdated language, so I'll just throw that out there. But he's so effective at capturing the kind of existential crisis that people who are really ill and injured face in the hospital, the sort of crisis of the self and the crisis of the spirit. And he helps make sense of, why we end up with some people who turn to faith and some people who turn away from it. And I just think it's shaped a lot of my thinking. It's worth checking out if you've never read it before. And then I know it's blurry, but the Journal of Religion and Health is sort of the flagship journal in this area, although there are many others. If you're interested in sort of up-to-date research on this topic, certainly the Journal of Spiritual Care would be another. So lots of good resources out there. And then I won't go into too much detail here, but I just want to say that there is a sort of subset of literature on religion and spirituality in rural healthcare in particular, certainly fewer articles and text, but enough to sort of build off of. And I'll just kind of mention that there's a good deal of work on how religion and spirituality inform healthcare decision-making and health behaviors, including access, or how people utilize healthcare, including mental health care. There's some good work on, in an international context. There's a lot of work coming out of Australia on rural health and religion. Some work on coping, I already mentioned. Some needs assessments that have been helpful in trying to survey, what do rural people want in terms of spiritual care. And then more recently, I think there's been a lot of interest in what kinds of things rural people need post-COVID in terms of religion and spirituality, what sorts of supports they need for, dealing with grief and serious illness and facing death and that sort of thing. So I know that's just kind of a flash lit review for you. But maybe I'll stop here for a moment and just see if there are any questions you'll have about this literature. Any ideas or thoughts? There's a lot out there, so. Okay.
Could you explain the concept of religious coping?
Religious coping. So that would be sort of using religious concepts to, maybe theological concepts, to make sense of, a serious illness or injury. Why? Yeah, exactly. Answering why. Why is this happening to me? And sometimes people do that well. Religion becomes a positive way of managing that kind of crisis of the self. And sometimes it's not, right? Sometimes religion makes people think that they deserve suffering or something, and so sometimes it's a sort of a negative coping mechanism, and it's helpful, I think, from the provider standpoint to start to figure out how is religion operating in this person's world, right?
I find it very compelling that you appropriately pointed out the subset of the spiritual but not religious category,
Yeah.
and how, my opinion is, that's just going to become the issue in terms of spirituality and healthcare in all environments, not just rural, because we've democratized, if you will, a lot of the rituals that were of the church. Big C, marriage is one of them. Now
Yeah.
people can be ordained and do your best friend's wedding and things like that. Now, I imagine that's going to be even more commonplace in the clinical setting, where in the absence of, quote, ordained clergy, there'll be a little bit more pressure on healthcare providers to suddenly find themselves in the crossroads of providing spiritual care, whether they're prepared to do it or not.
Yeah, that's a good point.
Yeah, I'll say on that point too, there's a movement in the chaplaincy field where people that aren't religious are becoming chaplains, atheists, or, so that is shifting the work as well.
I think,
It's less of that and more towards humanist.
I see one here and maybe one over here. So,
I have a question for you, even though we heard that great resume. The best resume ever. So are you teaching, I'm looking at your credentials, so are you teaching medical students this, and what's the name of your class? How does that work? And
great question. So the next part of my talk is going to be on medical education and sort of spiritual and religious issues. And I will just go ahead and tell you that the end of it is that we primarily teach this through electives at this point, which are research electives, kind of one-on-one tutorial models. But there are other models. So I'm gonna talk through in just a moment some of those other models at other schools. Yeah.
Hello, I'm Patricia Prime, and I am a registered nurse, a doula, and a lactation consultant. And so the question, I didn't know what to expect when I came to this conference, so I'm really, this summit. So I'm really excited that I came. But because I have my own business, I don't touch a lot of faith-based people in the work that I do. Not that I'm not a Christian, it's just I'm in the community pretty much doing the work by myself. And so I'm not looking to become a minister, but when I heard someone speak this morning that ministry is just about serving. And in this work, that's what I do. And so I just keep thinking about this mom that I was doing a home visit on. The visit was complete and I'm walking to the door. I get to the door and something prompts me to say, "Are you okay?" And when I turned back around, I said, "Are you okay?" And she was looking at her baby saying, "I just wish she had another mom. He doesn't, I'm not good enough." I'm paraphrasing what she said. You know, he needs somebody else. I wish he would just go to sleep and not wake up, that kind of stuff. And so, you know, in that moment, I just turned around and I did an assessment and, you know, we got her care. Today, she has 4 babies and is doing well. But before she left this area with number 2, she wrote me a card and at the bottom of the card, I shudder to think what would have happened had you not been in, and had you not seen me that day. And so, just being a part of this, just being able to come into this space and see where faith-based leaders and healthcare are really trying to bridge the gap. But there is a huge gap in what's happening in the community, what's happening in healthcare as we introduce faith-based leaders into this space. It's a lot more work that needs to be done, and I'm really just trying to find how to help to close these spaces.
Yeah, thank you for sharing that. Yeah, it strikes me that that might be a particular population that may be untethered from a religious community, even if they were part of a religious community kind of growing up, just because of their age. Potentially, if they're transient, they've moved a couple times in their young adult lives. So I'm glad you're doing the work that you're doing, and yeah, identifying people who need help, postpartum depression, that sort of thing. So thanks for that.
Yeah. It's right. Yeah.
Well, with all the research that you're doing on religion, is that to inform best practices for ministers or preachers or chaplains? Do we want to come up with a best practice on how we take care of either rural or in the city? Is that what the goal?
Paul, is that what we want to do? Best practices for... I think you just set out the mission statement. Yeah.
That is clearly one of the goals of the field, is to do this in an informed way.
Yeah.
And to provide care that, and to make sure that we're having the conversation, right? Because if you're in a rural space and you're not working together, what do you do with the person? So, sorry, that's too broad maybe, but yeah.
No, I think that's right. Yeah, I mean, we know that ministers and chaplains are doing such good work, and we know that physicians are doing and other healthcare providers are doing such good work, and we're hoping that we don't live in these silos when in the end we're, operating in the same spaces and dealing with the same problems in the same populations. So that makes sense. So as promised from the last question, I did want to say a little bit about what training in religion and spirituality look like in medical schools, the medical school here and sort of across the country. And then I'm going to pass it off to some students to talk about the great research that they've done in this area. I stopped using my notes. Let's see, behind. Okay. So we know that national healthcare organizations are really interested in spirituality and medicine. Actually, the American Medical Association just released this statement this year stating that they recognize the importance of individual patient spirituality, and they're really encouraging medical education curricula on spiritual health. Similarly, the AAMC, the Association of American Medical Colleges, has its own sort of toolkit for students to learn about how to, do a basic screening on religion for patients. So with those kind of national level agendas, medical schools are offering different sorts of programming along these lines. And I just want to give you some examples just to give you kind of some ideas. Some programs offer lectures and one-off workshops. Others offer like a track or a certificate in spirituality and health. Some embed a spiritual care curriculum in like a clinical skills course or a professionalism course because they're really focused on some of those communication tools that are necessary to navigate religious conflict. And then increasingly, I think some schools are trying to create more spaces for medical students to reflect on their own religious commitments and sort of be in dialogue with their colleagues and their faculty about maybe even controversial issues in medicine as they relate to religion. So those are sometimes built out by like diversity and inclusion offices and other times embedded in like a wellness curriculum. But at a lot of medical schools, including the one here at Mercer, we offer elective courses, which are essentially sort of tutorial research opportunities for students to work directly with a faculty member on a topic that they select relevant to faith and medicine. They explore a topic, discuss, write, present sometimes. We also have students in our summer scholar program who do a lot of this work. So in terms of the elective, I mean, we have students do all kinds of things. A lot of students who are interested in accommodations for religious people in healthcare, people who are interested in, students who are interested in why religious people might refuse certain kinds of treatments. I've had several students write about reproductive rights in relation to religious viewpoints, some historical papers on chaplaincy and like how the role of religion has changed in the healthcare space. I even had a paper called Religiosus Dermatosis, which was all about skin diseases that had a spiritual connection and, are now treated by physicians, but continue to retain some of those sort of stigma, I guess. But largely, our students, I think, approach these electives with the intent to improve, patient care down the line. So I really appreciate that. And I would like to, encourage more of them to reflect on their own sort of religious commitments in that process, think about their calling to medicine and help them sort of ground themselves before they go out into the health care field. So in terms of this faith and rural health initiative, we sort of had a multi-pronged approach. So, in a lab, in like a bench lab, everybody who's involved with the project takes one sliver of a larger project, and we don't do that as much in the humanities, but we got to do that in this project because it went over several years, and we were sort of, chipping away at a larger question. And we started with the narrative interviews that Paul talked about this morning. So we had some students going out to Putnam and Toombs and Berrien County, right? And talking to community members and faith leaders and clinicians about the sort of spiritual care needs within the healthcare space. That was a really productive sort of first step, and it created sort of the conditions for several summer scholars projects. And I'm sorry, we did have a student lined up to speak to us about his experience doing that, and unfortunately his family was affected by the hurricane, so he couldn't be with us today. But I was glad Paul already reviewed some of those findings this morning. So in terms of the sort of first round of summer scholars projects, we went into that summer with two sort of key questions. The first had to do with what is the sort of state of the field? So along the lines of the sort of synopsis I just gave you, what's the state of the field for religion and spirituality and rural healthcare? What sort of research exists out there that could help us better understand the problems that we're facing and the sorts of perils and possibilities of work in this area? And then the second question was about something like a landscape analysis that would help us get a sense of not the academic literature, but the sort of practical collaborations and projects that already exist on the ground that are doing this good work of pairing faith and health together in rural areas. So Persia Suarez took up up the first question. Persia will be here after this session, standing by her poster, so you can ask her about her literature review. And then Caroline Poole took up the second question, and she has recorded a quick presentation. Today was test day, so many of our students were out, but I'm going to play her presentation now.
Hello everyone, my name is Caroline Poole.
Can you hear?
I'm so excited to speak to you today and be part of the efforts of the Faith and Health program. I had the pleasure of working with Paul Bird and Dr. Caroline Anglim over the summer to do some preliminary research for the program, and I was mainly seeking to answer the question, how can we improve the health of our communities in rural Georgia through collaborative relationships between faith and health leaders? So I started to answer this question by doing a landscape analysis, which means that I was looking through research databases, looking online at publications, media sources, trying to find existing examples of these collaborative partnerships between faith and health leaders to improve the health of their community. So the presentation today will go through a brief summary of the types of initiatives that I found. I hope it's encouraging to you to hear about all of the wonderful efforts that are already underway all across the country, and maybe it will be sort of an inspiration to you if you're looking to join one of these collaborative. So one of the first types of initiatives that I found were health initiatives happening in faith settings. For example, having health education in the churches. So for these programs, a lot of the ones that I saw involved a health organization like the CDC, health departments, or local universities who would reach out to church leaders, and they would do a needs assessment together for their congregation or their community, and then develop an action plan that would specifically and uniquely address those health needs that they found in the assessment. For example, they might institute weekly health education small group sessions that are led by the healthcare organization personnel in the church. They might change church policies to have healthier meals at their events. Some even ask local farmers to come sell produce at the events. They might also institute exercise groups or an on-site garden. Another initiative in this area are foundations for faith-based health initiatives. For example, there's a group of churches in North Carolina who came together and decided that they wanted to fund health initiatives that churches were doing in their area. So far in their history, I think they're up to providing grants for over 900 churches. But some of the things that they fund could be developing walking trails on church grounds, starting smoking cessation programs, food pantries, health fairs, and first aid training for their congregants. Another initiative is using churches as telehealth hubs. There's a group called the Fishers of Men who are working to supply churches in rural Georgia with technology like computers and TVs so that they can invite community members to come to the church and have telehealth appointments with providers that they might not otherwise be able to access without the technology. There are also faith initiatives happening in health settings. For example, we have health networks. So for health networks, local congregations can enroll, and basically when a patient is admitted to the hospital, the intake nurse will ask them if they are part of a local congregation. If the answer is yes, then the hospital-employed navigator will come and talk to the patient and make sure it's okay with them to reach out to the liaison, who is a trained member from that patient's congregation. The liaison will then reach out and mobilize a team of volunteers at their church to help support that patient while they're in the hospital and when they leave. For example, they might look after the patient's pets while they're in the hospital, or drive them to follow-up appointments once they get out, or pick up prescriptions for them, things of that nature, which helps the hospital to ensure that their patients are getting good support when they leave the hospital and hopefully lessen the risk that they will have to return. Another initiative is hospital partnership with local clergy. So some hospitals have a pastoral services team that has a point person who will maintain a list of contacts with local faith leaders. And that way they have people to rely on when they need spiritual support, but also more support during times of crisis or disaster in the community. For example, the church might be willing and have a plan in place to shelter patients or hospital staff should a natural disaster affect the hospital. Also, the rest of the pastoral services team will make sure to collaborate with the clergy when they come in to see patients in the hospital and even document that encounter in the EMR record. There are also collaborative training efforts going on. For faith leaders, this might look like more health care education. For medical students and medical providers, this might look like more education on how to incorporate spiritual care into their practice, but also how to work with faith leaders in order to support their patients. So for faith leaders, there are plenty of organizations and opportunities out there for direct health education through in-person workshops or online webinars. A lot of organizations will provide regular newsletters or email chains that faith leaders can subscribe to learn about local opportunities for health education. There's a program through the VA that provides education to faith leaders on how to recognize and support veterans who may attend their church and have a mental health disorder of some sort. For medical students and providers, there are many medical schools who are starting to develop more spiritual care tools for their students. George Washington Institute of Spirituality and the University of Michigan are big players in this. They're starting to develop learning objectives and core competencies for spiritual care for med students. And in their doctoring courses, they have where students are learning how to take histories and visibles. They will incorporate taking spiritual histories and how to talk to patients about their spirituality in those courses. They also have opportunities for humanism rounds where they talk about the meaning of medicine and how spirituality of the healthcare provider plays into their care that they provide. There's also opportunities like on rotations, rounding with the chaplain in the ICU. Other collaborative programming involves mobile health clinics. As you can see on the top picture here, the Baptist Mobile Health Ministry is a mobile unit in Georgia that churches can request to be dispatched to their church. It has medical supplies and tools that church-recruited healthcare professionals can use to provide free services to underserved populations in the church's local area. Also, I'm sure many of you have been involved in health fairs. This bottom picture shows the Ask a Nurse program at a health fair where nurses come and do blood pressure checks and other health screenings. They can give general health advice and connect patients with further treatment with other providers if need be. So that wraps up my presentation. Thank you for your attention. I have my contact information here, but you can also reach out to Dr. Anglim if you have any comments or questions for me. Here's a link to a spreadsheet that I created with all of the specific programs I looked at and more details about each of them. If you're interested in that, you can follow that link. And here are my references. And thank you for your attention. I appreciate your interest, and I hope you have a blessed day.
Can we get a copy of slides to people? Do you know if that's doable? Maybe I can, we'll figure out a way to get the document. I know. Okay, so coming out of the summer of 2023, we were sort of wrestling with what could some of these like programs that Caroline found, what could we do to sort of get the ball rolling, maybe try out some pilot programs. So the first was thinking about how to create a sort of health behaviors sort of program that could be operationalized in a faith-based setting of some kind. And then sort of from the other side, what's maybe a spiritual or pastoral care training program that we could put in a health setting. So we had some more wonderful scholars come along and take up these questions. The first two were Anna Wiggins and Raina McKenzie, who are on our Savannah campus. And they took up that first question and developed a nutrition workshop for something called a med camp, which is a camp for middle school and high school students in Berrien County that Miss Beatrice Cunningham works on through her Pathways program. And they taught students how to cook. They gave them a cookbook at the end. They're just so enthusiastic. They taught them about macronutrients and micronutrients. And they evaluated, the impact of their intervention, and they have a poster out there that you can take a look at. But the hope was that something like that could be, sort of picked up and put into maybe a church setting where you have youth or some other community context. So that was really exciting. And then the second question was taken up by Hannah Jackson. Oh, I do want to mention that there's another poster out there by Sarah Cooper and one of our fourth-year students, Carlos Cespedes, that's about the med camps. So they ran some evaluations from students, and I think it might help fill in the blanks. If you're curious about what a med camp is, you can go talk to Sarah out afterwards. I'm so glad she's doing that work. So then our last question was taken up by Hannah Jackson, who's a second-year medical student here on the Macon campus, and also a member of our Bioethics and Medical Humanities certificate program. And Hannah put together a pilot training program for rural physicians on sort of the basics of a spiritual screening and kind of an intro type workshop for local physicians. So she's going to tell us about what she put together and what she learned. Thanks.
All right. Hello. As she said, I'm Hannah. I'm a second-year med student at Mercer. So I'll be discussing my research on incorporating religion and spiritual care into clinical practice. And like she said, I did a pilot workshop this summer. Let's see. Okay. Oh, thank you. Okay, so a primary motivator for this project was the positive impact that religion and spirituality can have on patient health outcomes. One study revealed that 90% of hospitalized patients utilize religion to cope with illness, and 40% of those patients view it as their primary coping mechanism. An additional study found frequency of religious or spiritual service attendance to be associated with a 25 or 27% reduction in all-cause mortality risk. And despite the obvious importance of religion and spirituality to a patient's healthcare experience, the majority of clinicians still refrain from discussing the topic, as has been discussed earlier in the day. So another motivator, the lack of discussion seems to be one-sided, as research has shown that most patients want religion or spirituality incorporated into their medical care. One study revealed that 83% of patients wanted their religious or spiritual issues to be addressed by their healthcare provider. And in that same study, patients expressed that if their beliefs were discussed in clinical practice, that they thought it would improve their physician's ability to encourage hope and give them more attenuated medical advice for them. So not only are these discussions desired by the patients, it seems that it would improve the patient's confidence in their physician's ability to treat them, and yet these discussions still are not happening. So the majority of clinicians avoid discussions of religion and spirituality with their patients because they've not been given the tools to do so. Most healthcare professionals don't receive any education on how to have these discussions in a professional setting, or how and when to consult a spiritual care specialist. In an effort to address this lack of education, I created a workshop designed to teach healthcare professionals how to incorporate religious and spiritual care into their clinical practice. So the workshop's curriculum was centered on 10 main objectives, the first being to define spirituality and religion. And this focused more on recognizing the complex relationship between the two rather than developing strict concrete definitions. As Dr. Anglim said, there's still a lot of debate about what the true meaning of religion and spirituality is. And the next two objectives were aimed at motivating participants by teaching them the benefits that these discussions will have on their patients and on their own clinical practice. Objectives 4, 5, and 6 were aimed at cultivating participants' ability to have these discussions. For this section of the workshop, participants were given cases and had to identify whether or not discussions of religion or spirituality would be appropriate, and then discuss the reasoning for their choice with other participants. They were also encouraged to discuss what phrases they might use to discuss these topics and how to cater to the needs of individual patients rather than using a one-size-fits-all approach. When discussing something as personal as religion and spirituality, it's important to have participants recognize any biases they may harbor for people whose beliefs differ from their own. For this reason, participants were asked to discuss how they might have these discussions with a patient who does not share the same beliefs as them, and how to avoid making their own beliefs the center of the conversation. Lastly, objectives 8, 9, and 10 were aimed at teaching participants how to recognize when their patients are in spiritual distress and what resources to utilize in these situations. Participants were told to treat spiritual care as they would any other specialty field. When the problem progresses beyond their scope, refer to an expert and collaborate to form a cohesive treatment plan. So in order to gauge the workshop's effectiveness, a pre- and post survey was conducted using questions centered on participants' comfortability and confidence levels with various aspects of spiritual care. For example, when asked how comfortable are you in bringing up spiritual or religious matters with your patients, 33% reported that they were very uncomfortable in the pre-survey. But after the workshop, 100% of participants reported feeling very comfortable doing so. Interestingly, 100% of patients reported feeling very comfortable praying with patients in both the pre and post survey. This may be due to prayer being or can be more passive depending on the person, and the nature of how it compares to active discussion, which can be more involved and more personal and require you to maybe express your own personal feelings more. Comfortability increased for identifying spiritual distress and formulating a spiritual treatment plan between the pre and post survey. Overall, comfortability was relatively high in pre-survey responses, which may be due to the high prevalence of religion in the southern U.S. Additionally, since participation was completely voluntary, so the clinicians that did participate might have been already very comfortable with the topic as they decided to. So it'd be interesting to see how the results would change amongst a group where participation was not voluntary. All right, and here are my references. Are there any questions? Yeah.
What made you decide to cover this topic?
For me, I am religious myself, and during all my time, because obviously before you go to med school, they're like, shadow, shadow, shadow. So I spent a lot of time in clinics, and a lot of people would have spiritual or religious problems, and instead of addressing it, I found that physicians a lot of times felt very uncomfortable, and they would kind of shut down that conversation and be like, oh, everything's going to be fine, like we'll do your labs, or we'll get back to you on this, and kind of avoid the conversation. And so I thought that it would be a good space to get in. It kind of needs improvement on our end, since if we can't even talk about it, how are we going to know where to send them or if they need help with something? Yeah?
Assuming there's a, you don't have to be there.
We need it for the recording.
Oh, the recording.
Okay. All right, this might be a little loud. Assuming you're continuing this vein, a concern I have is that the results can easily be confounded by the participants' previous religious knowledge, affiliation, depth, whatever you want to call it. And somehow I think you're going to need to weed that out or control for it, because until you can prove or show that there's no differential between the religious background of individuals when they get to this level, I'm afraid you're going to have meaningless results, okay? So I really encourage you to figure out some way to control for that.
Yeah.
Yeah, do you want to respond?
Oh, you can.
Okay, response, there's no response.
No, I think you're absolutely right. I think Hannah was getting at that when she was saying, maybe in the future, looking at groups that it wasn't a voluntary, sort of self-selected cohort would be interesting. The other thing I'll say though is sometimes being, steeped in a religious tradition doesn't clarify things for people in this space. Like they still need some training on how to sort of step back a little bit and allow the patient to set the terms of the conversation. Because they're super comfortable, they might actually approach it in a way that's inappropriate. So retraining is a real thing, sort of.
I agree with you, but I am not convinced it's not because of my background. I'm afraid that we may be reading things in to the participants that aren't really there, okay? I don't know if I'm making myself clear here, but it's very easy for me to say that, yeah, people with religious background, they should be very comfortable doing this, or they should not be at all because I might offend somebody. Whereas someone without a religious background, I may say, oh, they're going to be super sensitive to this, they're going to be very uncomfortable. May not be true, we don't know. And the problem is, if we clump all of those people together, I'm not sure we're getting meaningful results out, but I don't know how to separate them in a meaningful way. Good luck.
Thank you.
Any other questions?
I like that. In one of your earlier slides, where you were giving percentages, I believe it was 27% improvement on mortality. Would you please readdress that?
Yeah. So they were researching religious or spiritual participation, which could have been church attendance, prayer, or any kind of like devotionals, things like that. So like basically involvement in whatever they deemed their spirituality or religion. And then that was associated with a reduction in all-cause mortality risks, so like risk factors for mortality, not necessarily mortality directly.
Could you give me that in layman terms?
So basically, like Dr. Anglim was saying earlier, like we're not sure if it's whether it's like the community aspect of it or the religion spiritual like meaning itself, but it was associated with like better health outcomes essentially.
I'm Chrissy Bauman. My husband's a pediatrician and I'm a registered nurse, and we have a single physician pediatric practice in Greenville, Georgia. And I look at everything from a pediatric office point of view. And I understand that there's all these, people in the hospitals available. You can call them any time of the day and they'll show up and talk to your patient. That's not the case in our office. And I understand what they're saying about people's points of view and things like that, but I kind of view it as I would love to have the opportunity to have, like you were saying earlier today, like a 1-800 number we can call where we can get some kind of clergyman on the phone for some of our patients, because we in our office do deal with teenagers that are talking about suicide. We do deal with patients that are being diagnosed with some very serious illnesses. And not only that, but their parents and things like that. But there's not any place that we could call that, and I kind of look at it from, it would be really nice if we could have a place to refer them to as we refer them to like ENT or we refer them to whatever. And there should be some kind of standard that could be standardized. I mean, there's a standard for any other referral we do. That it would be really nice if there was a standard, and that way we'd cut out, it wouldn't matter what kind of, I personally have a Christian background, but for physicians in general, they wouldn't have to have a spiritual background if there was some kind of pattern and say, ask these questions, if this many questions add up, then call these people and refer them. It could be very simple, and these people could get this help. But the first problem is we don't even have anybody to call. Like, who do we even call? We're in a rural community. There's nobody to call. It's great for y'all to say that we should do these things. Who would we even call?
Actually, in the workshop, we addressed those problems on the part where we were covering like who to refer them to and stuff like that. There's actually now, post-COVID and everything, there's actually telehealth chaplaincy. And so offices can work with them and hire them either on demand or for a certain number of hours throughout the week to be available for any patients and schedule appointments like they would with any specialist. And then also we talked about how to kind of connect with your faith leaders in your community and use them as a resource and kind of build your referral base out of that. But yeah, a great new thing is telechaplaincy, which is a really great resource.
As a pediatric chaplain by training, the question you asked is very appropriate. And I love that there's a telehealth chaplaincy place. That's wonderful, and I encourage you to look into this. There are also other avenues that we're exploring through. So you've nailed a very appropriate and timely thing. And actually, I wish that was a paid advertisement, because we need those kinds of inputs. Thank you.
I might just add that we think about this a lot in our department as well when we're training physicians, because we want them to be aware of the kinds of resources that are available in a big hospital, which is likely where they'll do a residency, but also to sort of be prepared to serve a rural community. That's the mission of our medical school, and likely to be in a context where there's not a bioethics committee to call. And I just tell you the story that one of the first lectures I gave at the school, I got to the end and I thought I'd really made my point, and I gave them a case and I said, okay guys, what do you do? And somebody in the way back of the room said, call the ethics committee. It's like, no! So yeah, I think part of our job is to train clinicians to sort of be prepared to respond and to know what sort of resources are available in a context outside of a big hospital, academic hospital. So thanks so much for that suggestion.
Any other questions?
Hi, my name is Anglim, District Health Medicine in Healthy Communities. I just have an observation, and as we've been talking today, the theme has been between the clergy supporting providers and the patients. I've not heard any support for the clergy. Is there anything in place to help improve their well-being? Because as Reverend Kilgore said, there is a burden even when they are praying, even when they are teaching, that they do suffer, and they also internalize what patients are going through, when they are supporting them. So what are we doing to also support their well-being?
Clergy-like physicians make bad patients. You've really hit a really important point, that clergy tend to be isolated, and the amount of burnout among clergy is really quite significant. Clergy are leaving their positions. Sometimes they're being forced out because they're depressed and not responsive. So it's an epidemiological problem for sure. What the church structures can do is an open question right now. I do know that if you go into clinical pastoral training, one of the requirements is that you get psychotherapy. But that would be hard to prescribe for the parish clergy. So it's a terribly important problem. Clergy don't tend to talk to each other.
Any other questions?
Okay, can I add to what he said, please? I just want to add something. As clergy, we're pressed to wear S on our chest. We're Superman, when in all actuality, we're Clark Kent. And as he said about burnout and all of these things that are going on, and yet we are, for some reason, we're under the pressure to perform. If this family calls me at 2 o'clock in the morning, I got to go. Whatever happens, we feel like that. There's pressure to perform and to move and to be Johnny on the spot for families, married or wed, buried or dead, be there for graduations, be there for funerals. And it takes a lot, and a lot of times as pastors, preachers, our own families are neglected because we're busy trying to be everybody else's dad and trying to be everybody else's mechanic, and our car is the raggedest one in town. And it's real, the support is needed, and something that he said at the end, maybe you didn't catch. A lot of clergy don't talk to other clergy. So there's really, it should be a support system where every joint supply at the other inside of the body of Christ, but it's not there. It's not there. We really do need the support because I got things even now down in my own town was where the hurricane hit. And I got people calling me now. We got 10 trucks coming from here and 10 trucks going from there. And I'm here. I've been up here since Wednesday preaching. And I'm trying to logistically send trucks where they need to be because there's a need there. And it's just, sometimes ministry is overwhelming. It's overwhelming. I just wanted to add that.
Do you want to
No, you're good.
You're good.
Yeah, okay.
Can we give a hand? Oh, yeah. I think we're at the point where we need to start wrapping up.
I just want to say something to all of the clergy here. I am a preacher's daughter, and I have been, for this whole year, been working as the head elder at my church because we haven't had a pastor for 3 years. And I do understand that it's a lot that's going on, and there is not a lot of clergy support out there. But I want all of us to realize that you have a lot of support with your board. Put the board in place. Tell them what you're up under. A lot of pastors, you do wear that S on your chest, but a lot of times you will not allow the board to know what you're going through. So please use that support that you have in your inner circle, because the other pastors are out there, they're going through the same thing that you're going through. And I did not realize how much that my dad was possibly going through. I've been called to the ministry, but went into nursing. But I just want you to know, you have support right there. And I think this minister said it earlier when he was up there. You have to use the people that's right there. So before we close out today, we need to pull the pastors up and pray for them in the name of Jesus. Amen.
It's amazing how much we have to talk about. I want to say thank you very much to Dr. Anglim, to Hannah, for all the students and the research we've gotten. And they're asking questions that we're all very interested in. Let's take a small break. There are posters out in the foyer, and there's time to chat a little bit. And then I cannot wait for the next section. One, because we're closer to the exit, but most of all because I really can't wait to showcase what Putnam County and Coffee County have to tell us about what's going on, to maybe whet our appetite a little bit for what we do when we move out of this place. So thank you, and I'll see you back here in about, let's say right at the top of the hour, okay? We got 20 minutes.